Okay, good evening, everyone. It's 7 o'clock, so we are going to go ahead and get started. I'd like to thank you all for joining us at the online NATF support group. Just a quick announcement before we get started is to please make sure that you mute your lines during the call. The background noise can be really disruptive. So tonight we are delighted to be joined by Dr. Vin Pellegrini, who is the chair of the orthopedic department at the Medical University of South Carolina. And Dr. Goldhaber and I have the pleasure of serving on the Pepper series. And Dr. Pellegrini will tell you a lot about the Pepper trial in his presentation. So I know that a lot of you, this has been a really hot topic, and we've gotten a lot of questions about anticoagulants and surgery, especially orthopedic surgery. So we're delighted that Dr. Pellegrini is here to answer those for you. So without further ado, Dr. Pellegrini, I will let you take it away.
Thank you, Catherine, very much. Hello, everyone. I'm pleased to join you all tonight. And we'll plan to spend about 20 or 30 minutes of our time with a brief overview of really two things. One, the general subject of bleeding and anticoagulants used around the time of operation, which is always a challenging thing in and of itself. And then in particular, since I'm an orthopedic surgeon, we'll talk a little bit about the use of anticoagulants around the time of joint replacement surgery, specifically hip and knee replacement, and hopefully give you a little bit of background as to why this is such a particularly challenging problem, particularly in orthopedics, which may or may not seem intuitively evident. And we'll close up with a discussion of the trial that we're in the middle of that Catherine referred to. So the opening slide is really an introduction to the trial, which is called the Pepper trial, the pulmonary embolism prevention after hip and knee replacement. And what I'm going to present this evening is really some background information that we did some years ago, initially at Dartmouth when I was on sabbatical, writing the grant for this trial, in terms of getting information from patients and from people who have arthritis and were interested in considering joint replacement. So really patient perspectives about the use of blood thinners, anticoagulants, excuse me, and the trade-offs that go along with the use of those anticoagulants. I'm going to present the information in two parts, and I'm going to do some color commentary as we go along to help provide the context for the discussion, which I think is important. And the two parts I'm going to present this in are related to, number one, the first time we had a large-scale patient conversation about the issues, which was up at Dartmouth in Hanover, New Hampshire, about 5 years ago in preparation for the grant. That was a mini medical school forum that was done with patients who had not had operation and were not signed up for operation, but were interested in learning more because they had arthritis and were considering it. And then the second part is going to be a little more formal interrogation of patients that we did as part of a formal survey as part of the trial in South Carolina over the last year and a half as we kicked off the trial. So the next slide is my disclosure slide. We made a real habit over the last probably decade to provide any connections that we might have with industry. And my relevant connections really relate to the funding that we have from PCORI to run this trial and other research funding that I get for the Department of Defense that's totally unrelated to what we're going to talk about this evening. So this slide reminds me to tell you that these data that I'm about to share with you are derived from a conversation that we had in the mini medical school at Dartmouth about 5 years ago. This was when I was on sabbatical. And we talked at that point in time about the risks and the benefits of using blood thinners, anticoagulants around the time of hip replacement and knee replacement. The idea we're going to talk about tonight is the notion of pulmonary embolism as a disease. That's a blood clot that starts in the legs, typically, not always, and ends up in the lung, provides real trouble because it blocks the blood from being pumped from the heart to your lung. And we'll talk a lot about trade-offs in preventing pulmonary embolism and the role of patient decision-making in that. This slide, the comic, is a favorite cartoon of mine. It says the doctor isn't accepting any new patients anymore. He doesn't even like the ones he has already. And the reason for that satirical comment is that this really is, as the topic suggests here, the title suggests, a very religious and political topic. We don't really know the answer. That's the unfortunate saga. And hip and knee replacement is an incredibly common operation. This slide shows you how frequently the operation is done, and the quick numbers are that this year, 1 million total hip and total knee replacements will be done in the United States. About 2 to 1 knees to hips, so knee replacement is about twice as common as hip replacement. But obviously, both of them are quite common operations. And the thing that makes it even more in the limelight is it is the number one expenditure for Medicare in the United States. If you look at hip and knee replacement together, it's the single most commonly paid for operation by Medicare in the U.S. Interestingly, it's an elective operation. In other words, it's not a life and death operation. If you have a sore knee or sore hip and you leave it be, when the good Lord picks your number, you're not going to go because of a bad hip or knee. You're going to go with one. And so it's really a discretionary surgery, if you will. Nonetheless, this picture shows that the trend continues to go up. It seems to be unaffected by the economy, even though it is a discretionary surgery. And so the culture of Americans certainly is that increasing pain interferes with lifestyle. And as we all try to continue to live an increasingly active lifestyle, hip and knee replacement has become a much more and more popular operation. I'm going to pause here for 1 minute and give a little bit of context. So this is a slide of a pulmonary embolism that has been retrieved from an autopsy in someone who died from a pulmonary embolism. This tells us that over 40 years ago, when hip replacement was first developed, the prevalence of dying from a pulmonary embolism was about 1.5%. The prevalence has gone down substantially since then, over the ensuing 40 years. And the real question is, why in the devil does pulmonary embolism have to happen after hip and knee replacement with such frequency? Now, certainly this number for dying is not a high number, but if you take someone for an elective operation with no other medical troubles and they come in and you've got a 1 in 100 chance of dying, and started doing the operation, and now it's about 1 in 1,000. It certainly seems to be a preventable instance. And so the reason that this happens is that when we disturb the bone marrow inside the bone, when we put the prosthesis in the bone, in the hip, the pin goes down inside the femur, in the knee, inside the tibia and the femur, the fatty marrow tissue gets forced into the bloodstream. And it's curious because the fatty tissue in the marrow, once it gets into the bloodstream, it really turns on the clotting system in people. And so they become what we call hypercoagulable, or they're much more prone to make blood clots in their normal circulation. Whereas if they hadn't had an operation, your body clears tiny clots pretty routinely, and you don't make any extra clots. So the peculiar propensity that hip and knee replacement patients have is explained by the bone marrow fat that enters the bloodstream. We see this happen after people break their leg. When you break your femur, break your tibia, your thigh bone or shin bone, the fat, again, escapes from the marrow space in the bone and gets into the bloodstream, and people with femur and tibia fractures also have a very high risk of pulmonary embolism and deep vein thrombosis, blood clots in the leg. And so the short story is that orthopedic surgery in general, from long bone fracture, as we call it, or hip and knee replacement, is the most common elective operation that results in pulmonary embolism or deep vein thrombosis. And even more than that, it's the most common patient population in the hospital that is troubled with deep vein thrombosis and pulmonary embolism, much more so than people undergoing any kinds of general surgery, even much more so than people who have cancer and who are hypercoagulable by definition. So we have a very high-risk population who are subject to a very common operation and what would seem to be a very preventable death. Now, about 20 years ago, I guess it's 30 years ago now, 1986, was the last NIH consensus conference. And they decided and determined, because of the frequency of pulmonary embolism, it should be routine for people to receive blood thinners around the time of hip and knee replacement. And we now know, over 30 years later, that when people get Coumadin or warfarin, their death rate from pulmonary embolism is substantially reduced. So it goes from 1% or 0.5% to 0.1%, so 1 in 1,000. So it has become standard of care that an anticoagulant is used routinely around time of hip and knee replacement. The challenge is, when you think about it, we give anticoagulant when we put someone through operation. We don't want them to bleed. Operating causes bleeding. And to make it even more interesting, when we cut the bone bleeds until it's tired of bleeding. There's no blood vessel to tie off. There's no artery to coagulate. We don't have very good techniques to stop bone from bleeding other than using a tourniquet around the limb when we work. So here we've got a perfect storm. We have a commonly performed operation in hip or knee replacement. We have a high risk for increased clotting associated with disruption of the fat in the marrow space of the bone when we do hip or knee replacement. And the operation that we do, by virtue of the fact that we cut the bone, provides a very high risk scenario for bleeding in the same person that we need to give blood thinners to reduce the risk of blood clots. So that's really our challenge. And the question then becomes, what's the best strategy? And how often should we use blood thinners? How intense should the blood thinners be? What's an acceptable death rate? What's an acceptable blood clot rate? Ideally, we like to say none. So here are the numbers that we've presented to patients when we join in with them in a conversation to assess the risk and the trade-off between blood thinners and no blood thinners. So all comers with prophylaxis now, this is in spite of the best medicine that we have, let's just call it Coumadin traditionally. An unrecognized blood clot in the leg occurs in about a third of patients. One that causes symptoms and pain and swelling in the leg, 5 to 10%. One that results in a blood clot that grows, propagates, and spreads off to the lung, but doesn't cause symptoms in the lung or breathing, so small blood clot, 5 to 10%. The ones that we worry about are the ones that actually cause symptoms and are big enough to cause a problem, about 2 to 3%. And as we said already, dying from a pulmonary embolism in 2017 is about a 1 in 1,000 to 3 to 5 per 1,000 event. So not a never event, certainly, but an important event when it occurs. The other side of the equation is bleeding, and this is a patient of mine, very memorable patient now from about 25 years ago. We'd given a blood thinner after a knee replacement, and she bled into the wound, so much so that there was pressure under the skin, and before our very eyes, some of the part of the superficial skin died. So benign bleeding associated with a joint replacement when people receive a blood thinner intended to prevent blood clots, benign bleeding 10 to 20%. So a little bit of seepage about the wound that clears, maybe 5 to 10% when there is continued drainage. When bleeding causes a clinical problem and we have to change therapy or stop the knee from bending to allow the wound to settle down, about 2 to 5%. About 2% of those patients actually end up having another operation, as did this patient, to drain blood from the wound. And a few of those patients who actually have a serious bleeding issue around the wound will actually end up with an infection because the skin breaks down. And that's a disastrous complication, as you can well imagine, because patients end up having to have the joint replacement removed to clear the infection. So this is the trade-off. The trade-off is clot avoidance on the left side of the screen, and your risk of dying from a pulmonary embolism, let's say, to make the numbers simple, about 1 in 1,000, 2017, when we give you your blood thinner. And when we give you a blood thinner, we have a risk of bleeding. And the risk of bleeding may be 2 or 3%. It's clinically meaningful. And maybe 1%, let's say, of those patients have a risk of reoperation or even infection. So the risk of bleeding is about 10 times greater than the risk of dying from a pulmonary embolism. The risk of having a clinical problem with a pulmonary embolism but not dying, a couple percent, about the same frequency as the risk of having a clinical problem from bleeding, a couple percent. So this sets up the discussion, and I used a political analogy here. It looks like, I apologize, looks like the formatting has made this a little bit challenging. I'm going to try to fix it on the fly here and see if I can do that. And so what we have is a scenario whereby, there we go. What we have is a scenario whereby we have a choice to make, and that is very aggressive prevention efforts of blood clots in the leg and pulmonary embolism, which is naturally, intuitively going to result in a little more bleeding as return, but a much lower risk of having a problem that you would die from a pulmonary embolism. And on the right-hand side of the screen, we can say, well, let's be a little more cautious and conservative, and we really don't want to have so much bleeding, and we'll accept a rare pulmonary embolism death, and that's the choice. And we have no right answer, and the question is, in the instance when we have no right answer, it seems perfectly reasonable to engage the patient in a conversation about the relative risks and benefits of the treatment that they choose. They may choose a very strong blood thinner or a weaker blood thinner. And again, here's about the relative risk. So let's say if your risk of dying from a pulmonary embolism is X, as I explained it, the risk of having a bleeding problem is probably 10 times greater. But obviously, most of the time, you'll survive the bleeding problem, whereas as we define it, blood clot that is fatal, you're obviously not going to survive. And so that's the trade-off. So the question is, which would you choose and what do you think? And when we talk to these patients, and there are about 200 patients in the room, the auditorium up at Dartmouth, and these are people who had arthritis, had not had joint replacement, and they said, you know what? I'll accept a 1 in 1,000 risk of dying with a pulmonary embolism with a standard anticoagulant, which is a lower risk of bleeding. And 90% of the people chose aspirin because what they really wanted to avoid was that 2 or 5% chance of having another operation and bleeding. And they said, well, 1 in 1,000 is pretty low odds already, so I'll take my chance. And if you look around the room and there's 200 people in the room, you can reasonably rationalize the fact that no one in the room is going to die from a blood clot because there's not 1,000 people in the room, and 1 in 1,000 seems like a pretty rare event. So when we talk to this group of patients, the patients actually had similar sentiments as did the surgeons, and that is, we're going to do something to reduce the risk of blood clot, but we don't want to go overboard. can cause excessive bleeding by giving people a blood thinner that would increase the chances that they have a reoperation for bleeding or a clinical problem related to bleeding. And so in this instance, the sentiment of the, not patients, but lay people who were interested in learning more about joint replacement because they had arthritis was very similar to that of the surgeons. The surgeons are looking to minimize, obviously, pulmonary embolism, but also very concerned about bleeding problems related to the operation, which they want to minimize. So that was the baseline for which we went on and did the legwork for the trial. And the trial is all about comparing 3 commonly used blood thinners: aspirin, Coumadin, and Xarelto or rivaroxaban. And the trade-off is how much bleeding are we willing to accept with the stronger and stronger blood thinners that reduce the risk of dying from pulmonary embolism incrementally more, but in return for reducing the risk of death from pulmonary embolism, which is already relatively small, about 1 in 1,000, we get an increased risk of bleeding. And again, when we don't know the answer, it's perfectly reasonable to expect the patient to participate in the decision. And what this chart tells us, and again, I apologize for the formatting, it's a little bit off, but these are the guidelines that are promulgated by the American College of Chest Physicians, a widely respected group of lung doctors, that basically says all of these medications are approved and endorsed for use as blood thinners after hip and knee replacement. And what it also says is that we, the ACCP, doesn't have a preference for which medicine we use because we don't have enough information to say which one's better. So the message is, do something. Here's the choice of things that you can do, but we don't know which one works best. In general, warfarin historically has been the most popular. It's the very effective anticoagulant. It's a little bit tedious to use because it requires monitoring and the patient needs to get blood thinners. About 10 to 15% of surgeons prefer aspirin because there's not much bleeding risk. Low molecular weight heparin, let's just suffice it to say it's a popular medicine that is even more potent anticoagulant than warfarin and has a lower risk of pulmonary embolism, but a higher risk of bleeding. And so what this tells us is a survey of all surgeons says that people are kind of all over the map and there's no clear consensus. And what this slide tells us is that the more cases the surgeon did, which you see across the top, the less likely they were to use a very potent anticoagulant. The more cases they did, the more likely they were to use aspirin. When you look at low molecular weight heparin, the red line across, it really dropped down substantially after a surgeon was doing more than 130 or 140 cases because they really were concerned and were seeing more bleeding problems. So the study that we designed asked the question, which of these 3 commonly used medicines, already approved, no experimental drugs, is actually most effective? And not necessarily, or not only is it more effective, but we want to look at, with different patients, what are the different outcomes? Because it may turn out that we don't find one or another to be the winner, if you will, but rather for various circumstances with various patients, one drug may be preferable to another. And especially with patient preferences and specific preferences by any individual, one drug may be preferred by one patient, whereas a different one is preferred by another patient. And we picked these 3 drugs because they span the spectrum. So aspirin is the most conservative blood thinner, if you will, least risk of bleeding, probably the least good or least effective, we think, at preventing pulmonary embolism. But even with aspirin, it's a 1 in 1,000 chance of dying. But even a low risk of bleeding. At the other end of the spectrum, rivaroxaban, or Xarelto, as it's known by trade name, is the most thoroughly studied medicine for blood thinners after hip and knee replacement. It has a dramatically lower rate of pulmonary embolism. So now the risk of death with pulmonary embolism, we think, is perhaps 1 in 10,000, better than 1 in 1,000. And the risk of blood clots in the leg, whereas it used to be 20 or 30% with Coumadin, didn't cause trouble, is only a couple of percent, 3 to 5% with Xarelto. So a highly effective blood thinner. But in return, the risk of bleeding around operation is 3 to 5 times greater with Xarelto. So we designed this study in such a way that we tried to portray each medicine in the most effective way to use it. That means we actually modified the timing of rivaroxaban. That's the main change we did from standard practice. Instead of delaying the medicine for about 6 to 8 hours after surgery, we delayed it for 24 hours to reduce the risk of what we knew to be a higher chance of bleeding after operation, and hopefully get the benefit of the very favorable profile with reducing blood clots and lowering the chance of bleeding. So this is information that we gave the patients when we were given this survey. And now we're talking about patients in South Carolina who already signed up for operation. And we said to them, okay, you're coming to have operation. Here's what the risk of clots are. And here's what the risk of bleeding is around surgery. What would you choose? What would you like to have? We had most of the patients were before operation. We also had some patients that we had joint replacement previously, and we surveyed them after the operation. And basically, the most important thing, we gave everyone the same information, 500 patients, as the slide says. And we said, you know, your risk of bleeding with aspirin, about 1 to 10, your risk of, it looks like these are backwards, so that's not very good, is it? I'm very sorry. So your risk of dying from aspirin with pulmonary embolism is 1 in 1,000. And your risk of bleeding is maybe 1 in 10. And Xarelto had a 10 times greater risk of bleeding, so we exaggerated the trade-off. But your risk of dying was tenfold better. And so the question was, which are you more concerned about? Are you more concerned about the much lower chance of dying with a pulmonary embolism? You're about to have this operation, or a much more common risk of bleeding? And if you had to pick blood thinners, which would you rather do? So it's not very surprising that the vast majority of people faced with the prospect of an operation were most concerned about pulmonary embolism and the prospect of dying from that. So 85% of the folks were most concerned about that. No big surprise there. And the rest were split evenly between the concern about a deep infection or reoperation to drain the blood. We then went on and said, if we were going to look at this compared to before operation versus after operation, and we split out the people who answered the survey after they had the operation, interestingly, after they'd had the surgery and they now say, well, I've survived, it's much more likely I'm going to do okay, they became more concerned about reoperation for bleeding and bleeding that resulted in infection. So the views of the patients changed, perhaps not surprisingly, but it's important to understand that the patient's views changed from before having the operation to after the operation. So after the surgery, they were much more likely to perceive bleeding as the worst outcome and less likely to perceive pulmonary embolism as the worst outcome. So now we said, okay, here's a couple choices. If we gave you drug A and the risk of dying from a pulmonary embolism was 1 in 1,000, and the risk of reoperation for bleeding was only 1 in 100, so 10 times greater risk of having a bleeding problem, compared to a drug that further reduced your risk of dying from a pulmonary embolism to 1 in 2,000, so cut it in half, but your risk of having a reoperation for bleeding went up 5 times, which would you choose? And twice as many people said, I'm really concerned about dying. And so I'm going to have the stronger blood thinner, even though it results in a 5-fold greater chance of having a bleeding problem. And it only cuts my risk of dying in half. We said, okay, if that's true, suppose we had another drug It would further reduce your chance of death from a pulmonary embolism by fourfold if it meant a 20 times greater risk of bleeding. And 80% of the patients said, yes, I would take that risk of bleeding 20 times greater in return for further reducing my chance of dying. And so this is very different than the surgeons would have answered. It's also very different than those people at Dartmouth answered who weren't having an operation. They were just there kind of investigating. And so faced with the prospect of an operation, again, perhaps not surprising, the vast majority of patients, 80% of them, said they would really increase their risk of having a bleeding problem in return for reducing their risk of death as low as possibly they could, even though the change was incrementally smaller. Then we said, okay, now you understand the risk trade-off, and we know that here's the different drugs we're studying. Which drug would you choose? And their answers were rather irrational and hard to explain. And so I say with some tongue-in-cheek here that the patients are as confused as their surgeons are, because even though they wanted to act in a way that reduced their risk of dying from a blood clot as much as possible, which would lead you to choose Xarelto or rivaroxaban, in fact, almost half of them chose aspirin, which is the drug that had the least risk of bleeding trouble and the greater risk of pulmonary embolism. So it's hard to explain. I don't know how to explain this, other than the fact that perhaps patients just chose a drug that was more familiar. But in fact, they're not any more confused than their surgeons, because surgeons are all over the map in terms of which drug to choose. So now when we said before versus after surgery, so the pre-op patients on the left and post-op patients on the right, once again, patients were after operation. Now they've survived. As previously, they were less concerned, less preoccupied about pulmonary embolism, and more preoccupied about risking bleeding episodes, which occurred much more commonly than a pulmonary embolism. So patients who answered the survey afterwards were even more likely to pick aspirin and less likely to pick warfarin or Xarelto, the really potent blood thinners. And so how we would go about making that decision, we asked the patients, do you want to be involved in the decision? Would you like your surgeon to tell you what the answer is? Or would you like to have a conversation and kind of decide by consensus? And so about 1/3 of the patients said they would like the surgeon to just recommend what he or she thought was best. More than half, 60%, wanted to be a party to the discussion, which I think is entirely reasonable in the situation where we don't know what a clear-cut right answer is. And a small minority of patients wanted to be in control and make the decision themselves. So the interesting thing here is that in this particular circumstance, there was a majority of patients who were interested in a shared decision-making discussion that allowed them to have a voice and a vote, which is entirely reasonable, especially when we have some ambiguity about what's best. And then finally, prep for the trial, we said to them, well, now that you know how little we know about what the right answer is, would you be willing to participate in a trial? And more than half of them said we would be willing to participate in a trial that would randomly assign us to one of the 3 drugs, which gave us reassurance that the study would be well accepted, likely well accepted by patients to be enrolled, and helped us to get to the study done. And so I'm going to end with that and just say in conclusion, when we look about this trade-off with joint replacement, blood thinners to reduce the risk of blood clot, which can be fatal, but around the time of surgery, especially orthopedic surgery, is accompanied by a substantial risk of bleeding. The patients are much more accepting of the bleeding risk than their surgeons in return for minimizing risk of pulmonary embolism and death. And that's not surprising. Surgeons are more worried about things related to the operation that may be attributable to the surgical procedure, and certainly facing the prospect of a serious problem after operation, the patient understandably acts in a way to minimize their risk of having a fatal event. We also now know that patient perceptions change from whether we ask them before the operation or after the operation, because once they've survived the operation, they seem a little less fearful of the risk of pulmonary embolism and more fearful of the risk of bleeding, which occurs much more commonly. And so, most importantly, I would suggest one of the justifications for the trial, which will be to help understand which patients prefer what and which drugs are associated with different rates of bleeding and clotting problems. We will define some rates that will help give information that will provide a platform for a shared decision-making conversation with patients. So, in fact, patients can be involved in this decision-making process, especially if it turns out that there's no clear-cut winner between any one or another of the drugs. And with that, I will conclude my comments, stop talking, and open up the field for discussion and questions.
Great. Thank you so much, Dr. Pellegrini. That was excellent. And that we got a bunch of questions in over the chat function. So I'm going to go ahead and ask those questions. And then if we have a little time at the end, might try and unmute the lines, but we tend to get a lot of background noise when we do that. So the first question that came in the patients that you surveyed, did you ask them if they'd had a prior blood clot, a prior pulmonary embolism?
We did, because we know, it's a good question. We know, Catherine, that folks who've had a blood clot in the past are likely to do it again. So past history predicts future behavior. And so those patients are often a separate group. And so I should have said, question, and thank you for the question, I should have said that the patients in the survey are patients who did not have a blood clot in the past. In the trial, patients who have had a blood clot in the past, or if they've had a family member having a blood clot in the past, they're treated a little bit differently, because we know in practice today, people who've got a history of a blood clot, we generally give them a stronger medicine than aspirin. That's aspirin we think to not be sufficient prophylaxis for those patients. So in the trial, patients who have a personal history of a pulmonary embolism in the past are randomized to receive either warfarin or Xarelto. They cannot get aspirin.
Okay, excellent. Have there been any dosing studies done, or did you consider, giving different doses? For example, is it possible to take a lower dose of a blood thinner to reduce the blood clot risk, but that will also not increase the bleeding risk as much?
Yep, so another good question, and all that work has been done as a prequel to all these drugs being released on market. So the short answer to that with respect to the three drugs, aspirin is confusing. And so it's pretty clear that all you need is a baby aspirin twice a day to have a blood thinning effect that's sufficient to help pulmonary embolism problems. Coumadin, the INR, it's called the International Normalized Ratio. It's kind of the barometer, how we measure how thin the blood is. People have a heart valve or atrial fibrillation, irregular heartbeat. They're monitored with an INR in the 2.5 to 3 range, which is fairly intense anticoagulation. When we put people through operation, we lower that INR target down to 2 from 2.5 to 3. So we cut it in half. Again, because we're trying to find a happy medium that minimizes the risk of bleeding but still provides reasonable protection with blood thinner. And then for rivaroxaban or Xarelto, the dose has been worked out pretty well, and the dose for prophylaxis is 10 milligrams, which is half of what it is for people who have a heart valve or irregular heartbeat. But what we did in the trial, I think I mentioned earlier, what we did in the trial, instead of starting that drug 6 to 8 hours after surgery, because we know it already has a higher risk of bleeding because it's such an effective blood thinner, we delayed start of that drug by 24 hours. So the drug doesn't start for 24 hours after the end of the operation. Coumadin takes 24 to 48 hours to work anyway, so it actually is still as effective a start as Coumadin, but we pushed it back from surgery a little bit more, as I said, to optimize the use of that medicine, take full advantage of its advantages in minimizing the blood clot risk and trying to further minimize the risk of bleeding associated with it. So the doses were quite deliberately well thought out. There's been a lot of work on dosing and timing, and those are certainly important variables.
Mm-hmm. Okay, now you mentioned a little bit about an irregular heartbeat, and that kind of came up in a separate question in terms of a patient is on an anticoagulant because they have AFib and for stroke prevention. Yep. Would they be treated any differently than a patient who would be on an anticoagulant for pulmonary embolism prevention?
Yes, and so good question, and consistent with what we just talked about a little bit, knowing that we have a trade-off around time of operation because operation causes bleeding, we reduce the intensity of anticoagulation for people who are having a hip or knee replacement who are already on anticoagulation for atrial fibrillation. So the intensity of the anticoagulation for an operation is about half the intensity that we typically have people on with AFib. So for instance, the INR target for someone with atrial fibrillation is about 2.5 to 3. The INR target for someone, that same patient, who is going to have a hip or knee replacement, we lower the Coumadin dose and let the INR go down to about 1.5 to 2. Similar thing with Xarelto. The dosing with Xarelto is 20 milligrams with atrial fibrillation and only 10 milligrams when we're doing prophylaxis around time of surgery. So we reduce the intensity of anticoagulation around the time of operation.
Okay, great. Now, this is for a patient who was scheduled to have knee replacement surgery this summer and then unfortunately had a PE in July. How long should she wait before considering undergoing surgery again for her knee?
So in general, the conventional wisdom is 6 months. 6 months before you undertake operation, and that's for 2 reasons, really. The most important reason is that we know that you should be treated. People who have a pulmonary embolism, especially one spontaneously without any obvious cause, we generally anticoagulate them for 6 months after the pulmonary embolism. So the safest time then for you is to wait till you're off of the anticoagulation, and then you can have your surgery at a lower rate of anticoagulation that you would normally have for the operation itself without increasing your risk of bleeding. And knowing full well that the operation is going to increase your risk of a blood clot on top of the one you already had, it's best to get past that window. So 6 months is the time during which we typically will wait to have an elective operation after a pulmonary embolism.
Okay. Now, also from the same patient, you said earlier on that you're using Xarelto and Pepper because it's been the most studied in patients undergoing hip or knee replacement. If a patient's on another one of the new anticoagulants, should they be concerned about this, and should they consider switching to Xarelto for the surgery? Or is there thinking that they all kind of work the same?
So good question. So my answer is going to be a little tangential, but along the same spirit of the question. The most important thing to understand is that Xarelto, Pradaxa, all of the newer anticoagulants are the oral anticoagulants. There is no effective, specific reversal medicine on the market today. It's in clinical trials. It will likely be on the market soon, but it's not on the market today. So, in fact, to answer the question, all patients in my practice and in practice of many people who come in who are on Xarelto or Pradaxa for atrial fibrillation or any other reason, I convert them before the operation to warfarin, Coumadin, because we can reverse the effects of Coumadin. We can reverse the effects of warfarin directly if we get into bleeding troubles right around the time of surgery. So we now, until the trial's done and we know how Xarelto is going to fare, to be safe, we convert all the people who are taking therapeutic level now, more intensive anticoagulation, as I said, for atrial fibrillation or having a valve, we convert them to Coumadin because it is a reversible drug around the time of surgery. And then after a few weeks, often 2 or 3 weeks when I see them back in the office and take their sutures or their staples out, we put them back on the anticoagulant that they originally were on because of their cardiac condition.
Interesting. Okay. A patient who's on the call that has had 2 prior pulmonary embolisms, both after undergoing surgery, should they consider having a filter placed if they're going to undergo another surgery?
Right, great question. And so that question is as controversial an answer as the subject we're talking about now and what's the best drug. We know filters do a couple things interestingly and somewhat surprisingly. We know that the data tell us that there's no greater survival with a filter than without a filter. Somewhat shocking information, right? And so filters in general for prevention of pulmonary embolism are indicated if the person who had the pulmonary embolism in the face of appropriate and full anticoagulation prevention, and they had a pulmonary embolism in spite of that. If they didn't have full anticoagulation or appropriate anticoagulation, then no, they should be treated like other people, that they get prophylaxis measures before operation. And what I do in my practice, we see a lot of patients who have had a history of previous pulmonary embolism because they're sent in because we have this interest. We give them anticoagulation, Catherine, for a longer time after surgery. So whereas normally we give people blood thinners for a month after operation, and we get them back off after 4 weeks from the surgery, I will routinely keep people on for 3 months or so if they've had a history of pulmonary embolism. So the indications that people won't argue about for use of a filter are, number one, having a pulmonary embolism in the face of adequate anticoagulation. So the anticoagulation given didn't work or wasn't effective, obviously. Or number two, people who have a contraindication, an absolute contraindication to being on blood thinners of any kind. So for instance, that happens after trauma. If someone's had a head injury, we worry about them bleeding into their head, or they've had an abdominal injury, worry about them bleeding into their belly. So they have a absolute contraindication to anticoagulation, so they get a filter. But the short answer to the question is no, I would not necessarily go to use a filter. If someone had a PE twice before, we would modify the anticoagulation and optimize the use of blood thinners.
Okay.